A 27-year-old man A 27-year-old man comes to the physician because of 2-year history of severe muscle cramping and weakness. Immediately following what is written, calisthenics. I don't know what does it mean. After jogging a short distance, the cramping and the weakness resolved within 24 hours. He also had dark urine during this episode's neurological examination performed when he is asymptomatic shows no abnormality. Which of the following is the most likely diagnosis? The jogging.
Ready?
Ready?
Mhm. So it's muscle myocardial disease, muscle phosphorylates deficiency. Myocardial disease, glycogen storage disease that affect the muscle is characterized
How is
by
your
the
fatigue?
my fatigue a little bit better.
Okay, are you drinking like high potassium diet?
Mhm. Yeah, really trying. The morning is okay, but by 11, oof, it's like really bad.
Okay, like hypokalemic periodic paralysis. Today I read about this like hypokalemic, hyperkalemic periodic paralysis, and there
Mhm.
is Anderson-Twill syndrome. These are the channelopathies.
Channel.
Okay, and it is genetic.
Oh.
L- Like if usually it is not seen, but if symptoms appear, then you need to evaluate. Okay,
Hmm.
I'm not
I,
scaring you. I'm just giving you
I
some information.
because I'm like I don't know anybody in my family that has it. I don't know, but maybe. I don't know. Hmm.
Maybe
That,
if the fatigue does not improve, if fatigue increases, then you should ask your physician that is there any possibility of having these channelopathies.
mm-hmm.
Okay,
I think my
like
physician.
hypokalemic periodic paralysis, uh, one risk factor is stress anxiety. So you are
Mm-hmm.
in a stress, you are in anxiety situation, so it can aggravate in hypokalemic periodic paralysis. And another is high carbohydrate diet, but there is no history like that, but you are in stress, that's why. Okay,
Yeah. It's like my physician is probably tired of me just testing him every day. I have this. I have this. I have. It's like he's
no,
not even trying anymore.
if you like, if you if you can, what can I say, if you can make him understand, then he may think that there may be something wrong. Okay,
Yes.
because
It,
most of the people actually try to see it superficially, but sometimes there may be deep problem.
that's true.
Okay,
It's characterized by the inability of myocytes to break down glycogen as a result of the absence of muscular glycogen phosphorylase, which causes exercise intolerance with fatigue, cramping, and muscle weakness. Muscle cramping may resolve with rest or be permanent. Occasionally, a second wind phenomenon may be seen when blood flow to the muscles increases after approximately like 10 minutes of exercise, delivering fatty acids as fuel and relieving the need for glycogen breakdown. Patients may also have episodes of rhabdomyolysis accompanied by red-brown urine, a urinalysis positive for blood resulting from the presence of myoglobinuria without microscopic evidence of red blood cells. Complication of myocardial is acute kidney injury and acute tubular necrosis, secondary to release of nephrotoxic myoglobin and heme pigments in rhabdomyolysis. Treatment involves avoiding low carb diet and improving cardiovascular fitness with regular mild aerobic exercise. Okay,
Okay.
next.
A 77-year-old woman with mild dementia, Alzheimer type is brought to the emergency department by her daughter 3 hours after sudden onset fearfulness and combativeness. The patient lives with her daughter and son-in-law. She attempted to smash their television screen with her walker and struck her son-in-law when he tried to stop her. She has hypertension, GERD, diverticulosis. Her medications are metoprolol, omeprazole, triamterene, thiazide, hydrochlorothiazide, and donepezil. On arrival, she is hostile and accuses the physician of trying to steal her money. Her temperature is 37.5 degrees Celsius, pulse 74 per minute, respiration 16 per minute, blood pressure 144 by 82. Physical examination show restless movements. Mental status initially shows hypervigilance, but later he appears drowsy. She mutters under her breath as if responding to internal stimuli and picks up at the ear. Her mini mental status examination 10 out of 30. Results of which of the following diagnostic study are most likely to be abnormal in this patient?
Is it toxicology or is it urinalysis? Donepezil, triamterene, omeprazole.
Mm,
Okay, ready?
1 minute. Donepezil is given for Alzheimer's disease. Donepezil is anti-acetylcholine. It can cause this.
Mm,
Is there any possibility, or it is UTI? That's why it is happening.
I don't think it's UTI because the temperature is fine. It's
Normal.
probably for medications.
So
So,
toxicology screen.
but toxicology isn't it like a drug?
Drug
Like,
reaction.
oh, it can be drug. I thought it was drug of abuse only, but it's
But
drug.
urinalysis can happen. Urinalysis is
Okay, let's check. Is urinalysis is likely to be abnormal in this patient with delirium, which is defined by acute onset alteration of consciousness and cognition, with symptoms that wax and wane throughout the day. In elderly patients, especially those with dementia, systemic infection can rapidly lead to development of delirium. Other common causes of delirium include intoxication and adverse effect of medications such as anticholinergics, benzos, and opiates. Outpatient with delirium should be evaluated for evidence of systemic infection with urinalysis and culture. Um, Checks X-ray on occasionally with blood culture if indicated. Treatment of delirium should focus on treatment of the underlying infection if one is detected, frequent reorientation, maintenance of normal sleep-wake cycles, placement of patient in a calm and soothing environment. It's not Serum toxicology screening is frequently performed in the evaluation of delirium when a good history cannot be obtained or when there are signs of intoxication. This patient caregiver did not report a recent history of sustained ingestion, so toxicology screening is not helpful. Mm.
Okay. A 77 a 77-year-old woman is brought to the physician by her son because she recently has become unable to take care of herself and walk independently. Her son says that her ability to function has declined during the past 4 months because but she has not had any specific complaints. She has hypertension treated with that in April. Her only medication is 81 milligram aspirin. 6 hours ago, she had an MI on examination. Speech is confused. Her pulse is 72 per minute. Blood pressure 145 by 86 millimeter of mercury. Examination shows diffuse muscle weakness. Gait shows inability to ambulate. She can recall one of the three objects after 2 minutes. Results of the lab studies or within reference range. An MRI of the brain shows multiple small infarction throughout the both cortices and few in the thalamus. MRI of the brain shows multiple small infarction throughout the both cortices and few in the thalamus. In addition to adjustment to antihypertensive medication, which of the following is the most appropriate management?
Yeah, ready? Ready?
Yes.
Okay. So is no additional medication. Multi-infarct vascular dementia refers to cognitive impairment that results from acute cerebral infarction secondary to underlying cerebrovascular or thromboembolic disease. Patients with vascular dementia typically possess history of clinical strokes with consequent focal neurologic deficits and a stepwise decline in function. Some patients alternatively demonstrate silent cerebrovascular disease characterized by progressive neurologic decline and multiple small infarct on neuroimaging, as in this patient. This patient possesses risk factors for cerebrovascular disease such as hypertension and atherosclerotic disease, as evidenced by prior MI. Diagnosis requires evidence of cerebrovascular disease, clinical history of stroke, or neuroimaging evidence of infarct, and cognitive impairment. Management requires secondary prevention of stroke via blood pressure control. In all patients with a stroke history and many patients with silent cerebrovascular disease, antiplatelet therapy with aspirin is required. However, this patient is already on aspirin for the secondary prevention of MI. Those additional aspirin medication is not recommended. It is not long-term antithrombotic therapy in the form of enoxaparin, heparin followed by warfarin or warfarin only will be appropriate after acute ischemic stroke related to AFib, left ventricular thrombus or valve replacement. This patient does not possess a history of acute ischemic stroke, but instead presents with silent cerebrovascular disease, and she does not demonstrate evidence of cardiac indication for chronic anticoagulation. Mhm.
Okay. Next. A 62-year-old man is brought to the emergency department is brought to the emergency department 3 hours after the onset of double vision and left eye pain. 3 hours after the onset of double vision and left eye pain that he first noticed when she awoke. She describes a horizontal separation of image. She described horizontal separation of the image, which is worse for distinct as opposed to near vision. She has an 18-year-old. She has an 18-year history of type 2 diabetes mellitus. Examination of the left eye, mild adduction. Examination of the left eye shows mild adduction or primary gaze and severe weakness of abduction of the gaze on the left. The remainder of the examination showed no abnormality. The patient, for each patient with a visual disturbance, select the most likely lesion. Left type.
Ready?
Ready?
Mm-hmm.
What is your diagnosis?
I do not know. It is cranial nerve 6. Microvascular damage resulting from diabetes can produce neuropathy such as distal polyneuropathy, radiculopathy, or as in this case, cranial nerve palsy. Commonly affected nerves include the abducens nerve, cranial nerve 6, um, which presents with esotropia, unilateral abduction deficit, and diplopia in horizontal gaze. Okay. And the oculomotor nerve, cranial nerve 3, which presents with unilateral ptosis, exotropia, and hypotropia. Patients may experience associated ocular or periocular pain. It is important to exclude other possible causes of cranial nerve palsy, such as stroke, increased intracranial pressure, vasculitis, or optic neuropathy. Most patients with microvascular abducens nerve palsy experience resolution of symptoms over several months following treatment of the underlying cause. It is not. Where was I? Let me see this one. Cranial nerve 2, the optic nerve carries visual sensory information from the retina to the primary visual cortex via the lateral geniculate nucleus. Optic nerve defects can cause by the myelination of trauma and present with monocular vision loss. Cranial nerve 3, the oculomotor, is responsible for motor innervation of the levator palpebral superior, medial, and inferior rectus, as well as inferior oblique deficits of the oculomotor nerve, present with ptosis, exostrophia, and hypotrophia. Cranial nerve 4, trochlear nerve, responsible for motor innervation of the superior oblique deficits, present with diplopia, hypertrophy, and compensatory head tilt. Lesions of the what is it? Medial longitudinal fasciculus cause internuclear ophthalmoplegia, which presents with an ipsilateral adduction (ADD) deficit, characterized by inability of the affected eye to cross midline and an associated contralateral abduction saccade, as the contralateral eye undergoes more rapid nerve firing to attempt to pull the ipsilateral across the midline. Okay, next.
Next, a 35-year-old man comes to the physician one day after sudden onset double vision. Sudden onset double vision. He describes seeing two objects side by side. The farthest apart he looks at when he looks at the right. Examination shows the eyes move normally when he look to the left. When he look to the right, the left eye does not fully abduct. Sorry, the left eye fully adduct. There is nystagmus on the abducting eye. The remainder of the following is most likely. Okay.
Ready?
Yes, it is MS, optic neuritis, isn't it?
Mm, it's the medial longitudinal fasciculus.
Yes. Multiple
Contains
sclerosis.
mhm, contains interneurons that allow coordination of the oculomotor nucleus with the contralateral paramedian pontine reticular formation (PPRF) and abducens nucleus. Okay. During horizontal eye movement, abduction requires close coordination between the abducens and oculomotor nuclei. For example, during left gaze, impulses from the central cortical centers travel to the PPRF, to the left PPRF, um, to the left abducens nucleus, resulting in abduction of the left eye. Conjugate gaze requires symmetric adduction of the right eye via the right oculomotor nucleus. Lesions of the MLF cause internuclear ophthalmoplegia, which presents uh, with an ipsilateral adduction deficit characterized by inability of the affected eye to cross the midline. Mm, and an associated contralateral abduction saccade. Internuclear ophthalmoplegia may be unilateral or bilateral. In younger patients, such as demyelination associated with multiple sclerosis, is the most common cause, whereas ischemic stroke is the most common cause in older patients. Okay, next.
Okay. A 47-year-old woman with chronic alcoholism is brought to the emergency department acutely intoxicated. Other than her intoxication, physical and neurological examination shows no abnormality. Which of the following complication is most likely to be prevented by immediate administration of vitamin B1?
Mm, mm, ready?
Yes.
So it is retrograde amnesia. Damn it. Patients who chronically use alcohol typically demonstrate a significant B1 deficiency caused by poor nutritional intake, thiamine malabsorption, and impaired cellular utilization of thiamine. Over time, thiamine deficiency can result in damage of the and atrophy of the mammillary bodies, visible on MRI of the brain, which manifests as encephalopathy. To prevent encephalopathy, all patients with sustained heavy alcohol use should be given oral thiamine supplementation, and patients presenting with acute intoxication should generally be given IV thiamine. The typical clinical presentation of Wernicke encephalopathy is the triad of acute altered mental status, ophthalmoplegia with nystagmus and ataxia. The symptoms of Wernicke encephalopathy are reversible but increase the risk for development of Wernicke-Korsakoff syndrome in patients with alcohol use disorder if not immediately treated with high-dose IV thiamine. Wernicke-Korsakoff syndrome is a reversible condition that features psychosis and retrograde amnesia and consequent tendency to confabulate or verbalize false stories or memories to compensate for the inability to remember. It is not seizures. May occur in alcohol withdrawal. Thiamine does not prevent alcohol withdrawal. Induce seizures. Mm, Next.
Okay. An 82-year-old woman has had chronic bitemporal headache and diffuse achiness of the shoulder for 6 months. She has no history of serious illness. She has no history of serious illness and takes no medication. His temperature is 37 degrees Celsius, pulse 81 minute, respiration 12 per minute, blood pressure is 150 by 85 millimeter mercury. There is mild deformity of the distal interphalangeal joint. A range of motion is full. There is no edema. Examination show normal fundus. Uh, and neurological examination show no focal findings. Which of the ESR is 120? Which of the following is most likely diagnosis?
Mm, Ready?
Yes.
So it's polymyalgia rheumatica, most direct diagnosis in this elderly woman with myalgia, bitemporal headache, and markedly increased ESR. PMR, myalgia rheumatica, inflammatory disorder that often occurs concurrently with giant cell arteritis. Symptoms include proximal muscle and joint, shoulder, and hip girdle pain and stiffness. If untreated, muscle weakness may occur from disuse atrophy. Systemic symptoms such as fatigue are commonly seen. Diagnosis is clinical and treatment is low dose steroid for up to a year. It's common for patients to respond to steroid almost immediately, thus, the absence of response should prompt consideration of a different diagnosis. As GCA occurs concurrently in up to 20% of patients who have PMR, symptoms of throbbing temporal headache, vision change, and jaw claudication should prompt temporal artery biopsy and initiation of high dose prednisone. It's not what was that? Ankylosing seronegative inflammatory arthritis that most commonly affects younger men with a history of chronic low back pain and buttock pain that is worse in the morning and improves with exercise. Concurrent findings may also include uveitis, increased inflammatory markers, positive HLA-B27, pelvic X-ray sacroiliitis, although MRI is more sensitive. Fibromyositis, commonly used fibromyalgia. Consider, oh, it's not that one. And then polymyositis is inflammatory myopathy that can also present with proximal muscle weakness, but is frequently accompanied by weakness. Um, Inflammatory markers may be increased but are not specific. CK may also be increased and can provide a clue to diagnosis. Muscle biopsy is required for definitive diagnosis. Okay, next.
Okay. A 57-year-old man comes to the physician because of 1 year history of progressive difficulty. 1 year history of progressive difficulty hearing, especially on the right. Uh, he frequently needs to he frequently needs to ask people to repeat what they are saying. Eh, and especially children. Our partner has told him that he has been increasing the volume of their television at home, and the patient does not recall any related trauma, history, or previous dreams of war. Her 20 years ago, he has managed a nightclub. So 20 years ago, he has managed a nightclub that features live performance. He has no history of serious illness. He occasionally takes aspirin, ibuprofen, acetaminophen for headache or low back pain. There is no prime. There is no family history of hearing loss. Pulse 76, regular blood pressure 124 by 74. On examination, external air canals and tympanic membrane appear placed on their forehead and is heard better on the left. Air conduction is greater than the bone conduction bilaterally but clear on the left. Which of the following is the most likely explanation for this patient?
Ready?
Yes.
The sensory neural hearing loss. This patient history of occupational noise exposure, as well as his presenting signs and symptoms of high frequency hearing loss and normal conduction testing are consistent with the diagnosis of sensory neural hearing loss. Mm. Sensory neural hearing loss is typically caused by damage or loss of function of the hair cells of the organ of quality within in the inner ear. Presbycusis is the most common cause of sensorineural hearing loss and often occurs with prolonged exposure to loud noises. Exam typically discloses high frequency hearing loss, with the Rhine test demonstrating normal air conduction and decreased hearing in the affected ear. Okay. And the Weber test with decreased hearing in a Weber test with decreased hearing in affected ear too. Okay.
So
Lots of
presbycusis is sensory neural hearing loss.
mm-hmm,
So it is age related hearing loss.
mm-hmm.
Okay. What you are saying?
Oh, I wanted to read that one. Loss of mobility of the auditory ossicles is otosclerosis, which is in which the small bones of the middle ear undergo bony remodeling and loss of mobility. Otosclerosis present with low frequency conductive hearing loss and time tinnitus. Okay.
A 77-year-old man comes to the physician because of 3 week history of low-grade fever, fatigue, 3 week history of low-grade fever, fatigue, and severe headache, sensitivity to the bright light, 3 week history of low-grade fever, fatigue, severe headache, sensitivity to bright light, and pain in the hips and the shoulders. He has lost 3.2 kg weight due to decreased appetite. During this period, he appears ill. His temperature is 38.2 degrees Celsius. Examination shows mild photophobia but no meningeal signs. There is moderate pain on palpation of the large muscle groups of the shoulder and the hips. The remainder of the examination shows no abnormality. His hemoglobin is 11.1. Leukocyte count is 11,600 with normal differential. ESR is 85 millimeter per hour. Which of the following is the most appropriate next step in the diagnosis? So, age more than 50, yes, more than 50. Okay, ready?
One moment. Mm, mm, okay.
Okay,
So is temporal artery biopsy. This patient presenting findings of fever, weight loss, fatigue, headache, proximal muscle pain, photophobia consistent with GCA. GCA is autoimmune inflammatory vasculitis. Classic findings include fever, chills, weight loss, headache, history of preceding transient amaurosis fugax, jaw claudication, tenderness of the scalp, and pale optic disc edema. New headaches in an elderly patient should raise suspicion of GCA. GCA frequently occurs in association with polymyalgia rheumatica, which is characterized by stiffness and pain of proximal muscles. Results of labs show increased inflammatory markers. GCA is characterized by predilection to involve the vessels of the head and neck and often affects ophthalmic artery inflammatory occlusion, which can result in sudden ischemic damage to the retina. Once vision loss occurs, it typically is irreversible and commonly followed by vision loss in the contralateral eye within days to weeks. The diagnosis is confirmed with biopsy of the temporal artery demonstrating granulomatous vasculitis. Treatment is with high dose steroid should begin immediately once GCA is suspected in order to preserve vision. Okay, it is not nerve and muscle biopsy useful for diagnosis of vasculitis of myositis. These modalities have poor sensitivity for GCA, which does not typically cause nerve or muscular inflammation. Okay, next.
a previously healthy 42-year-old man comes to the physician because of 1 week history of moderate back pain. The patient originates in the right buttock and pain originates in the right buttock, radiates down to the posterior thigh and calf. He has not had any changes in the bowel and bladder. He has no history of trauma to the back. Pulse is 82 per minute, respiration 16 per minute, blood pressure 132 by 84 millimeter mercury. Sensation to the light touch is decreased over the right posterior leg and lateral feet. Muscle strength is muscle strength and deep tendon reflex are normal. Which of the following is the most appropriate next?
Mm, 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 mm. Mm. Ready?
1 second. Okay.
Okay, so it is ibuprofen therapy. Ibuprofen therapy is the most appropriate step in this patient who has signs and symptoms of consistent with the right S1 radiculopathy. Radiculopathy refers to neurologic symptoms secondary to compression of the spinal root, either as a result of an herniated IDD, so narrow stenotic neural foramen, or compression from extrinsic sources such as tumor or infection. Patient present with pain and occasionally with weakness in the dermatome or myotome supplied by the affected nerve root. Radiculopathy is most common in the lumbosacral region. This patient who presents with sensory changes affecting the buttocks, posterior leg, and lateral humerus highly has radiculopathy from a compression of S1 nerve root. The presence of sensory symptoms in the absence of motor symptoms suggests compression of the posterior nerve root as this contains sensory fibers. Compression leads to edema and inflammation of the nerve root and surrounding structures, which causes pain. This is most effectively treated with anti-inflammatory medications such as ibuprofen. Over time, most patients will improve with conservative care and daily exercise and physical therapy. It is not e. It is not nerve conduction studies can be performed in instances where the examination's findings are not diagnostically helpful. In this case, nerve conduction studies will confirm an S1 radiculopathy, but they are not necessary as the diagnosis can be made by physical exam alone. Okay.
Okay. Let's take 5 minute break. I'm coming.
Okay.
Okay. Okay.
Okay.
Okay. Okay, a 47-year-old woman is brought to the physician because of progressive loss of visual acuity over the past 6 months. A progressive loss of visual acuity over the past 6 months. Snellen chart shows Snellen chart shows a visual acuity 20 by 180. A photograph of the optic fundus is shown. The remainder of the examination shows no abnormality. Which of the following is the most likely causes of this finding?
Ready?
Yes.
With diabetic retinopathy, the patient found the findings of intraretinal hemorrhage, fiber layer, retinal nerve fiber layer interactions, retinal nerve fiber layer infractions, exudates and multiple foci of neovascularization. Okay, along with superior arcade are suggestive of proliferative diabetic retinopathy. Chronic hyperglycemia caused by poor control diabetes results in the position of advanced glycation end products within capillary vessels, leading to microvascular damage within the retina. This process results in retinal ischemia and clinical signs of microvascular damage, such as microaneurysms, retinal hemorrhage, retinal nerve fiber layer infection, and intraretinal edema and exudate deposition. These findings are characteristic of several stages of non-proliferative diabetic retinopathy. Once retinal ischemia becomes sufficiently severe, the increased production of vascular VEGF by the ischemic retina leads to retinal neovascularization, the hallmark of proliferative diabetic retinopathy. Neovascularization may lead to tractional retinal detachment, vitreous hemorrhage, and neovascular glaucoma, and it may cause permanent blindness. Non-proliferative diabetic retinopathy Is treated with rigorous glycemic control. Once neovascularization occurs, patients are treated with either intravitreal injections of monoclonal antibody against VEGF like bevacizumab, ranibizumab, aflibercept, or argon laser pararetinal photocoagulation to reduce the intraocular burden of VEGF. And to prevent complications of neovascularization. It is not, let me read the other ones. Acute glaucoma presents with pain, conjunctival injection, fixed mid dilated pupil, increased intraocular pressure in no visible fundus abnormalities. Optic nerve cupping is a feature of retinal, blah, 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 but it typically does not manifest for months after an episode of acute, whatever. A detached retina presents with decreased visual acuity and visible region of subretinal fluid. In tractional retinal detachment caused by diabetes, the traction is produced by a visible area of fibrobascular proliferation extending from retinal surface into the vitreous space. Macular degeneration is caused by dysfunction of the retinal pigment epithelium, and presents with signs and symptoms of visual distortion, scotoma, Dronsen, and neovascularization. Okay, next.
A 42-year-old man who immigrated to the USA 3 years ago, he tells the physician, he tells his physician that his hands are numb. He is being treated with isoniazid for tuberculosis. His features are mildly coarsened. Examinations show widespread patches, loss of pinprick, and light touch sensation, especially over the tip of the nose and the ears. The patches are oval and irregular, measure 2 to 3 centimeters. The common peroneal nerves feel thickened. Which of the following is the most likely diagnosis?
Ready?
Sorry?
Ready? Sorry. Mhm.
Yes.
So it is leprosy. Leprosy is a mycobacterial disease involving the skin and peripheral nerves. As the involved mycobacterium has predilection for the cooler areas of the body. The disease is endemic to developing countries. Um, Patients typically present with pigmented hypoesthetic skin lesion with associated paresthesia along with thick nerves and sensorimotor neuropathy. Okay. Likely as a result of an immune response leading to segmental demyelination. The most common affected nerves are the ulnar, median, common peroneal, facial, and greater auricular nerve. Presentation ranges from one or a few well-demarcated skin lesions with associated focal neuropathy known as tuberculosis disease to diffuse skin lesions and neuropathy known as the Prometheus disease. Um, from one of few well-demarcated skin lesions with associated focal neuropathy to diffuse skin lesions and neuropathy. Okay. If left untreated, neuropathy can progress and cause permanent disability, and the skin lesions can become nodular and repeatedly ulcerate, which may lead to coarse facial features. Um, Diagnosis is made by skin biopsy showing a CFAS bacilli within a cutaneous nerve. Treatment requires dapsone and rifampin along with clofazimine in the Prometheus disease. Neuritis is treated with steroids. Okay, next.
A 77-year-old man is brought to the emergency department because of confusion, lethargy, and excessive sleepiness. Like excessive sleepiness over the past 3 weeks. 3 days ago, he fall and struck his head on arrival. He has generalized tonic-clonic seizure last 40 seconds. He has hypertension type 2 diabetes mellitus and has history of frequent UTI and renal calculi. His medication include losartan, glyburide, trimethoprim, sulfamethoxazole. He is lethargic but usually aroused. His temperature is 37 degrees Celsius, pulse 110 per minute. Respiration 20 per minute, blood pressure 190 over 105, 190 over 105. Examination shows ecchymosis over the left scalp. Ecchymosis over the left scalp. The pupils are equally round and reactive to light. The pupils are equally round and reactive to light. Doll's eye oculocephalic maneuver shows full eye movement. Doll's eye oculocephalic maneuver shows full eye movement. Cranial nerves are intact. He moves all four extremities in response. He moves all four extremities in response to painful stimuli. Deep tendon reflex are absent in the upper and the lower extremity. Deep tendon reflex are absent in the upper and the lower extremity. Babinski sign is absent bilaterally. Babinski sign is absent bilaterally. There is occasional myoclonic jerk in the lower extremity. He is disoriented to place and time. Lab shows hemoglobin 9. Leukocyte count. Lab shows hemoglobin 9. Leukocyte count 7,500. Blood urea nitrogen 105 is high. Creatinine high. ALP maybe normal. So BUN high, creatinine high, and ALT is slightly high. Which of the following is most likely cause of this patient's lethargy? Ready?
No, one moment.
I can hear you. Are you
Oh,
there?
can you hear me?
Yes, now I can hear you.
One moment.
Yes,
Mm, ready. Okay, so it's uremic encephalopathy. Acute or chronic renal failure can lead to maybe they come here. Acute or chronic renal failure can lead to accumulation of toxins such as urea, which may result in uremic encephalopathy. This patient possesses several risk factors for acute renal failure, including diabetes, hypertension, frequent renal calculi. Um, the severity of mental status change typically correlates with the degree of azotemia. Encephalopathy typically occurs when the blood urea tonnage is greater than 100. Patients typically present with reversible neurologic symptoms including lethargy, disorientation, hallucination, and diffuse weakness. Signs of neurologic excitability, including tremor, myoclonus, and seizures, are also common. Coma may occur in severe cases. Increased BUN confirms the diagnosis. Hypertension, hyperkalemia, metabolic acidosis, and anemia are also commonly seen in patients with renal failure. Secondary to decreased filtration of potassium secretion, proton secretion, and EPO production. Management requires hemodialysis, which typically leads to symptom resolution. It is not, see, status epilepticus may present with persistent motor behavior if convulsive or decreased consciousness if non-convulsive. In non-convulsive status epilepticus, subtle neurological findings such as eye movement abnormalities, myoclonus, and aphasia may be demonstrated. Status epilepticus typically occur in patients with epilepsy or critically ill patients. Subdural hematoma refers to bleeding between dura and arachnoid membranes, most commonly caused by head trauma. However, this patient altered mental status was before his fall. Okay.
Okay, next. For the 10 days, a 40-year-old man has had pain in the left buttock, has had pain in the left buttock and posterior thigh that is exacerbated by coughing or sneezing. Deep tendon reflex are absent at the left ankle. Deep tendon reflex are absent at the left ankle. Passive flexion, passive flexion of the right hip with knee extended produce pain in the left lower extremity. An X-ray and MRI are shown. Which of the following is the most likely diagnosis? Passive flexion of the right hip with passive flexion of the right knee.
Mm, mechanical low back pain. Mm, mm, mm. Ready?
Mm, mm. Okay.
So it's herniated nucleus pulposus. You can see it right here. Can you see it?
Yes.
Yeah. Uh, Herniation of the nucleus pulposus through a tear in the surrounding annulus fibrosus is the mechanism behind herniated lumbar disc. This herniated disc can potentially compress um, adjacent spinal nerve roots, leading to severe back pain with associated paresthesia, numbness, pain, and or weakness of the lower extremities in a dermatomal or myotomal distribution. Herniated disc may be caused by degenerative changes, trauma, or acute strain on the vertebral column. Um, L5S1 disc is the most common site of this herniation. The straight leg raise test or Lasegi sign is performed by passively flexing the hip while keeping the knee extended. A positive straight leg raise test is highly sensitive but not specific for an ipsilateral herniated disc. In this case, the MRI also showed posterior herniation of the L5S1 disc with associated effacement of the adjacent central spinal canal. Um, yeah. Treatment involves NSAID, physical therapy, and local heat application. Importantly, the patient should continue the regular activities such as possible rather than rest. If the patient has any signs of neurological deficit, including weakness of the lower extremity, bladder, or bowel dysfunction, surgical intervention may be indicated. It's not fracture of the pars interarticularis occurs secondary to movement that causes a load on the spine. Um, it is seen in a child and adolescent at least most often and presents with low back pain during activity, which increases gradually. It may also cause paresthesia and radiating pain to the buttock or thigh secondary to associated spondylolisthesis. On examination, lumbar extension will elicit the pain. It's not spinal stenosis, narrowing of the spinal canal, often secondary to degenerative joint disease, which results in compression of the nerve root or spinal cord. Um, Patients may present with symptoms of radiculopathy, including back pain that adheres to the buttocks and legs, blah, blah, blah. Hip extension increases pressure on the nerve root, hip extension, while flexion of the hip release pressure in the case of lumbar spinal stenosis. Okay.
Okay,
Mm-hmm.
next. A 52-year-old man comes to the physician because of a 3-month history of insomnia. He has difficulty falling asleep because of restlessness and feeling of ant crawling inside my leg. He does not. He notes that he has no constant. He notes that he has no constantly move his legs to relieve the sensation. He often has to undercover his legs and hang them over the side of the leg to get some relief. The symptoms on now occur almost daily. He has milder symptoms during the day and generally moving around, so the sensation is not noticeable. Physical examination shows no abnormal HbA1c 13.5, sorry, hemoglobin 13.5, HbA1c 5.6, and serum ferritin 15. Thyroid function tests are showing normal. Which of the following is the most appropriate pharmacotherapy? Is it RLS?
Probably. Ready?
Yes.
It's ropinol. RLS is a common idiopathic movement disorder characterized by unpleasant sensation in the legs during periods of rest or sleep that are partially alleviated by movement and lead to significant degree of emotional distress and functional impairment. The cause of RLS is not currently known but may involve abnormalities in iron homeostasis and dopaminergic signaling. Patients often have positive family history. A variety of structures have been implicated in the pathogenesis of RLS, including the thalamus and basal ganglia. First line treatment is with lifestyle modification to improve sleep hygiene and with dopaminergic agonists such as um, ropinirole.
But nowadays, aropinerol is not given. What is the drug?
Don't know what
Alpha
is
2
it.
delta calcium channel ligand.
Mm, like the
Pram, sorry.
which ones? The gabapentin and all that?
Yes, gabapentin, pregabalin.
Mm,
Pramipexole, like dopamine agonist, pramipexole lopinirole is not used nowadays.
oh, okay.
And serum ferritin is 15. If serum ferritin is less than 75 nanogram per ml, then supplemental iron should be given.
That's like
And
75.
for mild intermediate symptom, carbidopa levodopa can be given. And frequent, like this patient, frequent daily symptom, alpha 2 delta calcium channel ligand.
Okay.
Okay.
Got
Can
it.
you tell me the risk factors of the RLS? One is
Low,
given IDA,
yeah, low
uh,
iron.
iron deficiency anemia, uremia, pregnancy, diabetes, MS, Parkinson's, and the antidepressant, antipsychotic, anti. Okay.
Okay.
A 57 a 57-year-old man comes to the physician because of increasing problems with the memory. He reports that he was fired from his job as an accountant recently because he was no longer able to maintain accurate accounts. He has an he has a 5 year uh, he has a 5 year history of facial grimacing and involuntary arm and the leg spasm that have been become increasingly severe. He has hypertension treated with captopril. There is no family history of neurologic illness. The patient's father died at the age Patient's father died at the age of 28 years of injury sustained in a motor vehicle collision. The patient has never smoked cigarettes and he does not drink alcohol, use illicit drugs. His temperature is 36, pulse 80 per minute, respiration 20 per minute, blood pressure 142 by 82 millimeter of mercury. Neurological examination shows frequent asymmetric involuntary movements of all extremities that are random and jerk like. On mental strategic examination, he recalls 0 to 3 objects. After 5 minutes, he cannot name the current president or recall the meaning of proverbs. The MRI of the brain show which of the following. What is your thought? Is it Huntington?
Probably. Mm, Huntington was what again? It's not substantia nigra. It's not this one. Was it cowdead nucleus? I guess. Ready?
Are you sad for any reason?
No. Why?
Because Trump has initiated the war.
Oh my God! Yeah. No. I'm. Can you notice it in my voice?
Yes, I can feel
Yeah.
it.
Like
Like, uh, like, like what bad thing Trump actually activated. He actually throw some missiles, like missiles from the what can I say, from the ship, the
Mm-hmm.
nearby ship.
Mm-hmm.
So the Iran now is planning to destroy those ships or nearby troops.
Yeah.
So they will planning to do that. And what missile they are actually throwing? There is no clue of anyone in the world. Even US do not have those kind of missile. Today they sent such a missile that Israel did not actually detect when it came. Is it that super fast? You got
Mm.
my point.
Yeah.
So I it was actually coming down. If he took 2 weeks, it will come down. But today he actually escalate everything after
Yeah.
sending the B2 bunker buster.
Oh, it's giving me headache. Oh, mm.
Now it becomes scary.
Yeah. I'm worried about my brother. I'm worried about myself here. I'm
Yes,
worried about my
because
yeah.
when you have nothing to lose, you will you can do anything because they have to survive. Otherwise, they will become one Iraq or Syria. So they
Yeah.
will give their best and they will do whatever they can. So
Yeah.
they started saying that they will target the nearby troops or ship.
Mhm.
And it is possible to attack one of the ship or one of the troops. It is not
Mm.
impossible. That is like Trump is actually playing with the people of the US. Truly,
Yeah. Yeah.
they he has he he do not think about them. He is thinking about his benefit. That's the most sad part.
Yeah,
L-
because when the war starts, he's gonna go in his bunker with his family and you know, like
Yes,
yeah.
what what Netanyahu is doing. Netanyahu is doing exactly like that. He is showing that he has done a lots of things. Like his son has not married due to this war. He has done lots of sacrifice. Is it sacrifice?
Jeez,
World is full of clowns.
I swear, really. Okay.
Sometimes I think that the people actually like told by the US media and other media that they are bad. Actually, I start feeling that they are good because they are fighting for their country. But
Mm-hmm.
US people and US senator, they are actually throwing the military recruits. What they have done, their right is to fight their country. Their right is not to fight the others country, isn't it?
Mm-hmm. Yeah, that's true. That
Okay,
is true.
so sorry for that.
Uh,
I know you are very sad because of this, because you know war has escalated. Everybody in the US know that.
Huntington disease is a hereditary progressive. At this point, I don't even know if we're going to take the steps because if there is war, they're going to close everything here. And I'm
No,
not.
no. Why you are thinking about US?
I'm just like, I don't, because the US, we always think like we are untouchable, like nothing
No,
can
no.
stop the, the you know.
It can be touchable, but the escalation will happens in the nearby US military sector,
Mm-hmm,
because they will attack, uh, uh, and they will attack through those troops. You got my point.
mm-hmm,
And another thing has happened today, like Iran has closed their Hormuz uh, site. This is the site. This is where 20%, more than 20-25% oil coming through that route.
mm-hmm,
You got my point. In the sea, there is like Hormuz Pranali, and from that route, actually, the US and other Middle East and everywhere in the oil comes through those routes. So lots of thing will happen.
mm. Jeez. No, some of the senators here, the other senators, the Democrat senators have told us already to just try to avoid like gatherings, like with a lot of people.
Oh, they are why they are doing,
Mhm.
they
Why?
are doing it because people are very frustrated with Trump, and lots of
Yeah,
people
yeah,
in the
people are,
US
yeah,
actually came down to protest against what you are doing. You are throwing our money for no
yeah,
reason. You are throwing our son, you are throwing our daughter for no reason. He is
yeah.
actually uh, falling lots of. Uh, do you know about Tucker Carlson? He is one of he is one of the previously he is one of the CNN reporter. Actually, CNN throw him out because he is a true person, and then
Mm-hmm,
he has an own YouTube channel, and
mm-hmm,
he asked Ted Cruz, one of the senator, maybe in the
mm-hmm.
Texas.
I know him. Mm-hmm,
Yes, he asked how many people live in the Iran. He do not know anything about Iran, and he
I
stopped.
think I saw not the whole video, but I
Yes,
saw.
you have seen the reels. I know it is
Mm-hmm,
so very popular. And you even Trump promised that he will not escalate the war, and what he is doing,
mm-hmm,
he is actually escalating all the wars.
mm-hmm,
He can't. If Putin and like China is with Iran, then it will
mm-hmm.
gonna a very, very big war.
Yeah, that's why I mean they are saying, okay, guys, not like some of the other senators, the ones that are against Trump, they're like, don't worry, but please try to avoid like gatherings. And then the one in New York, I think the mayor, he said that he deployed more police to,
Yes, it is because
yeah,
of recently there is like he the
hereditary progressive neurodegenerative disorder typically arising between 30 to 70, associated with atrophy of the caudate nuclei in the basal ganglia, which can be seen on MRI. The disease usually presents with insidious onset of psych and cognitive symptoms like irritability, depression, psychosis. Motor symptoms like chorea, hypotonia, dystonia, loss of voluntary control of movement typically appear later in the disease. Hmm. People with Huntington typically die 10 to 40 years after disease onset. Chorea, a key Huntington symptom, can be initially experienced as restlessness. Treatment is symptomatic and can include tetrabenazine and deutetrabenazine, which target chorea by depleting dopamine stores. Huntington is caused by expansion of CAGs, CAG repeat on chromosome 4, which occurs when a series of three nucleotides, well, we know that Huntington also demonstrates anticipation, a genetic inheritance phenomenon in which future generations are affected at a younger age with more severe um, symptoms. It is not atrophy of the thalamus, may be an isolated finding in multiple sclerosis. However, Huntington characterized by atrophy in the caudate nucleus, not the thalamus. It's not increased, what am I? T2 signal of the globus pallidus, putamen, or subthalamic nucleus will indicate edema, inflammation, infection, and tumor of this in these structures, not atrophy. Along with caudate nucleus, these structures make up the basal ganglia responsible for stimulated or inhibited movement. Okay, next.
okay. A 47-year-old a 47 a 47-year-old woman is brought to the emergency department a 1 hour a 1 hour of a 47-year-old woman is brought to the emergency department 1 hour after the sudden onset of headache. She says that she was walking from work to her car when she felt an explosion in her head, causing her to fall to the ground. She is not sure if she lost consciousness. Since then, she has had a severe headache characterized by double vision and throbbing pain exacerbated by head movement. She has hypertension treated with atenolol. She has smoked 2 packs of cigarettes daily for 20 days. Her pulse is 80 per minute, respiration 16 per minute, blood pressure 148 by 82 millimeter mercury. Examination shows left ptosis. Examination shows left ptosis. The pupil is 6.5 millimeter and the left pupil is 6.5 millimeter, right pupil is 4.5. Upward gaze and adduction of the left eye are limited. The CT scan of the head shows diffuse subarachnoid diffuse subarachnoid blood, a lumbar puncture, show a lumbar puncture uh, while a lumbar puncture yields gross bloody CSF. Cerebral angiography is most likely to show sacral aneurysm in which of the following locations? Is it subarachnoid hemorrhage?
Mhm. Ready?
Yes.
So it's left PCA, posterior communicating antenna. Circular aneurysm are focal dilations of cranial blood vessels, dilatation, sorry, caused by underlying weakness of the vascular wall and frequently occur with vascular risk factors such as hypertension and smoking, or with inheriting collagen vascular disease such as Marfan and Ehlers-Danlos. Rupture of circular aneurysm causes subarachnoid hemorrhage, we present with severe headache of precipitous onset, nausea, vomiting, meningitis, coma, and potentially death. These patients' symptoms of ptosis, hypotropia, exotropia, and mydriasis are consistent with a diagnosis of third cranial nerve oculomotor nerve palsy. A new oculomotor nerve palsy raises concern for the presence of a circular aneurysm in the ipsilateral PCA. Upon leaving the brainstem, the oculomotor nerve courses beneath the posterior cerebral and posterior communicating arteries and is vulnerable to aneurysm compression at this location. The fibers responsible for control of pupil are found on the superficial aspect of the oculomotor nerve and are thus first affected by external compression. This distinguishes acquired oculomotor nerve palsy caused by aneurysm compression from palsy caused by microvascular ischemia, which typically spares the pupil. The detection of a new oculomotor nerve palsy is a medical emergency and should prompt immediate search for a potential aneurysm. As aneurysm rupture can lead to life-threatening subarachnoid hemorrhage, PCA aneurysm is diagnosed via CT scan, MR angiography, or conventional angiography. A rupture aneurysm can be treated with clipping and endovascular coiling. It's not B. I was between B and what was the other one? B and D. It's not B. Bifurcation of the left middle cerebral artery and the origin of the left anterior cerebral artery are both common sites of circular aneurysm. However, circular aneurysms at these locations do not lead to compression of oculomotor nerve and do not cause oculomotor nerve palsy. Okay, next.
Okay. And a 72-year-old woman comes to the physician because of 4-week history of involuntary movements of her tongue and jaw. She has 3-year history of intermittent nausea. Medication includes psyllium metoclopramide. Medication includes psyllium metoclopramide, ranitidine, calcium carbonate, and bismuth subsalicylate. Examination shows leaking movements of the tongue and side-to-side movements of the jaw. There is mild slowness of limb movement. Which of the following drugs is most likely cause of this patient's symptoms? Ready?
Mhm. So it's metoclopramide. Metoclopramide is a dopamine receptor antagonist and muscarinic receptor antagonist. Uh,
Agonist.
agonist. Utilized for the treatment of nausea and gastroparesis. Nausea and gastroparesis. Okay. Metoclopramide targets nausea via central and peripheral D2 antagonism. D2 antagonism in the basal ganglia can potentially cause Parkinson, leading to the bradykinesia in this patient. The chronic use of antidopaminergic agents may regulate D2 receptors in the basal ganglia, leading to tardive dyskinesia. Tardive dyskinesia is a syndrome of involuntary movements of lips, smacking, or reactatory movements of the tongue. Since tardive dyskinesia is not fully reversible for some patients, those on antipsychotic medication or metoclopramide should be closely monitored for the development of tardive dyskinesia. Management involves reducing the dose of the offending medication and or switching to a medication that does not cause potent to antagonism. Vascular monoamine transporter inhibitors like tetrabenazine can also improve target discrimination by depleting dopamine store. It is not E. I was confused between E. Where is E? E, 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 E. Ranitidine is a H2 receptor antagonist that decreases gastric acid excretion and is utilized to relieve reflux symptoms and dyspepsia. H2 antagonists may act on CNS to cause somnolence and confusion, but do not lead to involuntary. Okay, next.
A 22-year-old woman gravid to para 1 aborta 1 comes to the physician because of two episodes of blurred vision in the left eye, one episode on the right-sided weakness during the past 3 years. She has had urinary urgency frequency with some episodes of incontinence during this time. The first episode of blurred vision occurred after a motor vehicle collision 3 years ago, during which she sustained a fracture of her left humerus and soft tissue contusions. She has used an oral contraceptive for the past 2 years. She has smoked one pack of cigarettes daily for 3 days. She is of Northern European descent and she has lived Southern US for her entire life. Vital signs normal. Fundoscopy examination mild pallor of the left optic disc. Visual acuity is 20 by 80 on the left and 20 by 25 on the right. Neurologic examination shows mild right hemiparesis, bilateral ataxia of the finger, nose, and heel shin testing. The remainder of the examination shows no abnormality. MRI of the brain shows multiple areas increased T2 signaling of the uh, periventricular white matter and the white matter of the cerebellum. Which of the following is the strongest predisposing factor of this patient's condition? It's MS, isn't it?
Mm, okay. Mm, 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 mm. It's probably strongest risk factor. One climate. Where does he live? Smoke. Well, southern south. Mm, MS small ancestry northern Europe. I'm between climate and ancestry. Northern. I don't know. Okay, whatever. Ready?
Yes.
Okay. I'm pretty sure it's gonna be one climate. Oh, ancestry. Good. The patient's presentation with neurological symptoms separated in time and space. MRI findings demonstrating T2 hyperintense lesions in the periventricular and cerebellar white matter suggests a diagnosis of MS. MS is a immune-mediated demyelinating disease. Risk factors include female sex, white, age 20 to 40, residence in temperate climates, and ancestry. It is associated with HLA-DR2. Presenting symptoms depend on the location of the lesion. Optic neuritis is a common initial manifestation and typically presents with poor visual acuity and consequent afferent pupillary defect on physical exam. According to McDonald criteria for multiple sclerosis diagnosis, patients must have evidence of the myelinating lesions that are separated in time and location. This evidence can be based on subjective symptoms and or imaging evidence. This patient presents with episodic progressive symptoms over the course of 2 years, with physical exam and MRI involving the left eye, corona radiata, and cerebellum. Okay, oligoclonal bands of immunoglobulin indicating immune overactivation can be found on CSF but are not necessary for diagnosis. Treatment includes steroid for symptomatic management of acute flare and long-term modifying treatments such as interference or monoclonal antibody. It is not the residence in a warm climate is not predisposing factor for multiple sclerosis. Rather, residence in a temperate climate has been what is temperate climate has been associated with an increase. What is temperate climate?
Temperate, is it? Okay, let's see.
Okay. Okay. So a climate that has like a lot of seasonal changes like hot, cold, winter, all that.
Warm in summer and cool winter.
Like it has all the seasons. Like
In our
okay.
country, there is all this.
Yeah. So that's what they mean. I'm thinking. So it's not too hot. It's not too cold. It's in the middle. Yeah. Okay. Next.
Okay, 4 days after hospitalization for internal fixation of the femoral fracture sustained in motor vehicle collision, a 32-year-old man became agitated and disruptive. His temperature is 100.4 degree Fahrenheit, pulse is 124, respiration 24 per minute, blood pressure 180, blood pressure 180 by 100, 180 by 100. She is, he is diaphoretic. He is diaphoretic and picking at his bedsheet. Fundoscopy examination shows no abnormal mental status, psychomotor agitation and disorientation. Hematocrit is 40%, leukocyte count 7,000. Which of the following is the most likely diagnosis?
Mm, mm, mm. That's fever.
Is it alcoholic
I guess. Yes,
or
yes.
is it fat?
Fat embolism, it doesn't it cause PE and PTK?
Yes.
Yeah, maybe I cause it. Okay.
Okay.
So yeah, Colin, when this patient um has likely developed delirium tremens, serious complication of alcohol withdrawal. Alcohol increases the CNS activity of GABA, the main inhibitory neurotransmitter. Abrupt discontinuation of alcohol therefore leads to relative sympathetic excess. Uncomplicated alcohol withdrawal typically presents with tremors, anxiety, restlessness, headache, nausea, diaphoresis, which can occur hours after the cessation of alcohol. Delirium tremens, the most common concerning and life-threatening complication of alcohol withdrawal, involves severe confusion and disorientation, fluctuations in consciousness, agitation, visual hallucination, autonomic instability, variable pulse and blood pressure with hyperthermia. As in this patient, delirium tremors typically begin like 2 to 5 days after patient last alcoholic drink. Patients with delirium tremors may die from associated dysarrhythmias and respiratory failure. The delirium tremors is managed supportive with benzo to address agitation and prevent withdrawal symptoms, IV fluids, nutritional supplementation, and frequent assessment, including vital sign check. Other complications of alcohol withdrawal include alcoholic hallucinosis, auditory and visual hallucination without confusions or autonomic instabilities, and seizures.
Okay. Can we stop for today?
Sure,
Okay. Take rest. You are
I'll
very
wait
sad.
now.
You should
I'll,
you should take a good sound sleep. Otherwise,
yeah, I think
you
I'm
will
gonna.
become sick.